lymph adenopathy, and CT also suggests there is evidence of lung nodules, right? It's lung metastasis, most likely. So an impression being a locally aggressive thyroid mass with significant mass effects and possible metastasis. So, clinically and radiologically, also they're thinking of a thyroid carcinoma. So a thyroid FNA was requested. So on the examination, revealed a very huge thyroid, more prominent on the right side, and aspiration was subsequently performed. So you can see there is a cellular smears with a very blood-stained background. You can see, as what Prof. Sharifah had said, it's a clean background without much colloid. And also there's no lymphocytes in the background to suggest another entity, which I'll share later. So at higher magnification, you can see that there is actually very cellular smears and the cells actually forming microfollicular patterns, right, at higher power. Okay, some are actually singly dispersed, right? All of them are predominantly of neoplastic cells showing similar features. In areas, significant nuclear crowding and overlapping are actually seen. Okay, so this is a bit of loose area. Actually, we can actually appreciate the nuclear features better. It actually shows these pale neoplastic cells with pale nuclei, right? With very weak nuclear grooves, very weak, but other area you can't actually appreciate that. So they have abundant granular cytoplasms, right? At higher magnification, you can actually see there's an inspissated colloid materials. So when you actually go and look at the nuclear features, typical nuclear groove and pseudo-nuclear intranuclear pseudo-inclusion actually not very prominently seen. So, all right, this is MGG stains showing a microfollicular pattern, and at this magnification, you can actually appreciate there is some mild to moderate nuclear anisonucleosis. They have abundant, if you agree with me, they have abundant granular cytoplasms, right? So this, we proceed with a cell block, and it shows similar features for microfollicular patterns, follicle patterns with abundant eosinophilic cytoplasm, which suggests a Hurter cell change. So, so we give a diagnosis of consistent with a follicular neoplasia, Hurter cell type, Bethesda 4. So because we do not have we cannot categorize them anywhere, but we give a footnote that it could possibly represent a follicular carcinoma, Hurter cell type, in the right clinical and radiological context. So fair enough. 1 week later, they proceed with a total thyroidectomy and cervical lymph adenopathy, lymph node resection, and the tracheostomy was actually performed. And these are the samples that they sent. So we received a total thyroidectomy specimen. Is actually a very huge thyroid that we received, and section shows a complete replacement by the tumor cells of the right lobe, and the left lobe and the isthmus are unremarkable. So this is the section from the right lobe. It's basically, it shows a complete effacement of the thyroid tissues by malignant cells in solids. You can see there's a solid nest, some trabecular formations. Extensive areas of hemorrhage are noted, but there's no necrosis seen. So more of rather solid areas with in area they show follicular patterns, right? If you can appreciate the cells are rather uniform with very mild anisonucleosis, right? They have abundant eosinophilic cytoplasms. So lymphovascular invasion is very easily recognized. So surprisingly to us, lymph node section from lymph node also showed evidence of metastatic malignancy. Is complete replacement by the malignant cells. So a diagnosis of follicular carcinoma, a Hurter cell type or oncocytic variant with lymph node metastasis was given. So before I proceed with discussion, I would like to go on with case 2. It's more or less a similar case. a 66-year-old female presented with a 3 centimeter very small thyroid, solitary left thyroid nodules. And she noticed that the mass was gradually increasing in size, and an FNA was performed. So in this case, you can actually appreciate there is a papillary structures. Okay, so there is a very cellular smears with sheets of neoplastic cells forming papillary architecture, and you can actually appreciate there's numerous bare nuclei seen in the background. Okay, at higher magnification, you can see that the cells are relatively enlarged. Okay, with nuclear mild to moderate nuclear pleomorphism, and most important, you can appreciate that is they have a kind of powdery nuclear chromatin patterns, right? And it's clearly seen, better seen here with a nuclear groove is also noted. But in other area, we find this, there's a very round dark nuclei with abundant granular cytoplasm. So it makes us wonder, whether we're dealing with follicular follicular neoplasia or a papillary or thyroid carcinoma or oncocytic variant. So anyhow, we put it as because of the clinical so we put it as because of the nuclear features. So we favor that of a papillary carcinoma oncocytic variant. Bethesda 4 was given. So a thyroidectomy was performed. So it's actually a very small lesion with the serial section actually show from thyroid lobe, it shows a very small nodules measuring about 3 cm. Is located intrathyroidally, and surprisingly to us as well. So this is a very solitary nodule separated from the thyroid, even though it's inside the thyroid itself. So this is a thyroid, and with a parathyroid tissue separated from it, encapsulated. So in higher magnification, you can appreciate that the neoplastic cells are relatively enlarged, showing solid nesting patterns, right? Separated by delicate vascular network. So mitosis is actually seen as shown by arrows. Okay, so since we'll like to confirm whether this is a parathyroid tissue, which we may need not to, but we did it. We did a PTH, is actually positive, very wall-to-wall, show wall-to-wall positivity. So a diagnosis of intrathyroidal parathyroid adenoma was actually rendered. So yeah. So however, 7 years later, the patient presented with progressive enlarging multiple lobulated neck and anterior neck swelling, chest swelling, with largest measuring 3 centimeter in largest dimension associated with a raised PTH. So a CT scan was done, show a very huge mass, measuring 7 centimeter at the thyroid bed with evidence of lung metastasis. So a FNA of the anterior neck mass was subsequently performed. It shows similar features, a very cellular smears with cells, neoplastic cells forming microfollicular pattern. It's just like a follicular, we are dealing with a follicular neoplasia of thyroid. But since this is a known case of a parathyroid adenoma, so we proceed with a cell block and do a PTH. So lucky enough, this PTH is positive again. So diagnosis of parathyroid neoplasia Curie recurrence is random. So we don't commit that at that point of time whether it's a CA or adenoma, because it's actually very difficult to diagnose it cytologically. But anyhow, knowing that this is a recurrent with multiple huge nodules in the thyroid bed and the anterior chest wall swelling, so we know that in the back of our mind we're dealing with a carcinoma. All right, so a resection of the neck swelling and all the anterior chest wall swelling was actually performed. And you can appreciate that this is the neoplastic cells was actually separated from by this dense fibrous septa, right? And there is evidence of capsular invasion as well. So this time there's more nuclear pleomorphism, but there's not much of different from the previous previous resection specimen, and mitosis is actually seen. All right. So this time a diagnostic of oxyphilic parathyroid carcinoma was given. So, but we have an MTT on this, whether or not this case is a missed parathyroid adenoma, parathyroid carcinoma 7 years ago, or whether this is a progression of a parathyroid adenoma to parathyroid carcinoma, we're actually not sure, because last time we actually reviewed back the case, there is no capsular invasion at that point of time. So yeah, so there's still a question. Right, so I'll go on with some quick discussion. Hutter cell in thyroid FNA. I think it's already discussed clearly, thoroughly by Prof. Sharifa earlier. Just go on very quickly. Hutter cell was first described in way back in 1894, before we were born. All right, it's actually initially describing a parafollicular C cells in the thyroid instead of the follicular-derived follicular cells. So it was later, 4 years later, correctly identified by this pathologist, Ashkenazi. It was accurately diagnosed, it's actually recognized lah. Then it was termed Hutter cell, Ashkenazi cell, oncocytic cell, and oxyphilic cells. So it can use interchangeably. So oncocytes basically it means swelling in Greek. So it's characterized by a large cell with abundant eosinophilic granular cytoplasms, and they have a prominent nucleolus, as what explained by Prof. Sharifa earlier. Why they have this granular cytoplasm? Because they have abundant mitochondria within the cytoplasm, right? So this is a typical Hutter cells. So when you encounter Hutter cells in the FNA, it's actually very difficult because they have a wide range of differential diagnosis. It ranges from a non-neoplastic up to the neoplastic lesion, So it's very difficult for us. So careful cytological examination is actually very important, right? So non-neoplastic lesion, you will have you always have to think of Hashimoto thyroiditis or hyperplastic adenomatous nodule with Hutter cell change. Okay, Hashimoto thyroiditis usually, as what mentioned by Prof. Sharifa, is very easy. It's most of the Hashimoto thyroiditis we can diagnose cytologically, where they have a very typical cytological features with polymorphic population of lymphocytes, okay, with tangible body macrophages. And Hutter cell usually is just a minority of population. You will not see Hutter cell that much, as well as the follicular cells. At the background, you also will see very scanty colloid as compared to colloid nodule. So when this entity cause problem is when the smears, okay, when we aspirate, we only get the Hutter cell rich areas. And the smear and the background actually show very scanty lymphocytes. So it actually poses us a diagnostic dilemma when this case happened. So some tips to favor thyroiditis over HCN, Hutter cell neoplasia, is that when you see there's absence of discohesive cells, when you see absence of nuclear pleomorphisms and absence of prominent nucleolus of Hutter cell, more favor Hutter cell neoplasia. All right, so there's another entity which mimics HCN, is a benign colloid goiter with a Hutter cell change. Also, this one usually is very easy to diagnose, but at times it could be difficult when there is when the smears and the aspirate is not very good. Okay, so in this entity, we compose predominantly of macrofollicles with abundant color at the background. So Hutter cell usually is a minority of a component as well. So in case of a cystic degeneration, you may see some macrophages. Right, just a revision of what had been mentioned by the presenter earlier. Okay, neoplastic lesion, these are the entity you may want to entertain in case of when you see Hutter cell in the FNA. So oncocytic variant of PTC, PTC at times, as what mentioned by Prof. Sharifa, is okay. We can actually diagnose PTC confidently by cytology. If we see all the nuclear features, all right, we have a powdery chromatin nuclei with irregular racinoid nuclear features. we have, if we see the cells have prominent nuclear grooving and nuclear pseudo inclusions. Sorry, cytoplasmic intranuclear pseudo inclusions. So what if we do not see all these features? So it will give us, we will be like on not too confident to diagnose this entity. And what is worse is the nuclear features of Herter cell. It could be paler, mimics that of a PTC, which pose a diagnostic dilemma to us as well. And sometimes this Herter cell tumor will have calcified structure, which resembles samoma bodies. Okay, but we can actually always resort to do immuno, which I like the most. Okay, if you ask my trainee, I will actually ask them to do cell block for most of my cases. So right, so we can do CK19, Galactin-3, and HBME1. If you have in the center, you can do. So it's actually very helpful to differentiate them from other entities. But bear in mind that some follicular lesion and Herter cell lesion also can be positive for these markers. So you have to be interpreted carefully with the right clinical and cytomorphological context, right? So, all right, so we go on to follicular neoplasm, Herter cell type. You can use HCN interchangeably, Herter cell neoplasia. Right, so it's very well described. When you do an aspirate, you can see the smear are usually very cellular, composed predominantly of Herter cells, with very scanty colloid in the background, similar to follicular neoplasia, but it's just that they have a Herter cell change. And most of them, they have prominent nucleoli, and the cells tend to be very discohesive. So this is the literature. It shows that two very useful features to diagnose HCN over non-neoplastic Herter cell lesion is that there is a presence of transgressing vessels and intracytoplasmic inclusions. Okay, whether or not we can diagnose HCC versus HCA from FNA alone is actually no. It's actually very difficult. Gold standard is still by histology, but there are some studies done to trying to distinguish between the two entities. Basically, the goal to reduce the number of patients to undergo unnecessary lobectomy. So the patient can undergo one steps for near total or total thyroidectomy. Okay, so these are the cytological features that they suggested. A small cell, the smear usually be very hypercellular, and there is a very significant nuclear crowding, overlapping, and there's this small cell and large cell dyscrasia. But anyhow, no matter how many research, so many research have done, using this criteria, they only able to identify 60% of cases. So it's actually not very useful. And at the end of the day, histology is still the gold standard to diagnose HCC, Herter cell carcinoma. Right, let's go on to briefly on MTC. It's easily mistaken for HCN because of they have this tumor is actually very the smears usually composed of very cellular smears, and they are very thinly dispersed, just like that of HCN. They have abundant cytoplasm as well, but they have salt and pepper chromatin patterns. What is different from HCN that is usually have inconspicuous nucleoli. Very occasion they will have nucleoli, but not too common compared to HCN. And what I noticed from CBAS is that in MTC they say this MTC entity they tends to have red granules as compared to Herter cell neoplasia, they tend to have a blue granules, which I still wonder until now. I'm not sure whether I'm colorblind or what. His CN to me is still look a bit purplish, not quite blue. All right, so if you see amyloid is a bonus, okay, we can do immuno. It's actually very useful. You can do just calcitonin or chromogranin. It's very useful to exclude this entity or to rule in or to rule out this entity. Okay, parathyroid neoplasm, as in the present case, actually is almost indistinguishable from follicular neoplasia. Alright, they look almost the same. Okay, so they tend to have a large three-dimensional clusters. They show pseudo-papillary structures, as in our case as well. We see papillary structure as well. So they say these parathyroid tumors usually have smaller, darker nuclei with abundant coarse granular chromatin and inconspicuous nuclei. So usually they have lack of colloid material. So in case of high index of suspicious is needed in dealing with such cases. And if you have such a suspicion, you can do a cell block, and immunohistochemistry usually very helpful in such instance. You can do PTH, like in my case, or you can do CATA3, and typically they'll be negative for thyroid markers. Okay, another entity that mimics HCN to perfection is the metastatic RCC, renal cell carcinoma. So in this RCC, they tend to have round, relatively uniform nuclei, depending on the nuclear grading, depending on the grading of the malignancy. They have abundant granular cytoplasm, like that of Hurter cell neoplasia or follicular neoplasia or Hurter cell types, and they have abundant vacuolated cytoplasms. Okay, so clinical history of RCC is actually very helpful. If there is such a history, then we will do a cell blocks, and as usual, immunohistochemistry actually, you have no problem if there is a positive for CD10 or RCC markers and negative for thyroid markers, so you can diagnose confidently. Okay, so approach to diagnosis. My approach to diagnosis. So at low power, you will look at the cellularity. So when the smear is actually very cellular, composed predominantly on oncocytes and many isolated discohesive cells. So you need to think of neoplastic process as listed down here. Or if there is a mixed population of cells with predominantly composed of macros follicles, which is not so cellular, and then you look at the background. Don't focus only on the cells, look at the backgrounds. If there is presence of lymphocytes, abundant lymphocytes, polymorphic population of lymphocytes, please think of Hashimoto thyroiditis. And if it's composed of abundant colloid, so you will want to entertain a colloid nodule with Hurter cell change, right? Okay, so we'll go on quickly on this. So dealing with a PTC, you need to have a typical nuclear features of PTC, immunohistochemistry like galectin-3, CK19, which I usually do if I encounter PTC in a suspicious of PTC, especially those cases. MTC usually have a red cytoplasmic granules, right? So I think there's a typo here. Usually they have rare prominent nucleolus, and in case cell block is actually very helpful, you can proceed with immunohistochemistry. So you end your nightmares. You have a good diagnosis. You can sleep well. And the parathyroid neoplasm, which usually if you're not suspecting it, you tend to miss it, because they actually mimic the follicular neoplasia. It's a known potential pitfall. So you will see what I want to emphasize here is the immunohistochemistry actually very helpful. And metastatic RCC, again, clinical context. In the right clinical context, you may want to do some immuno to rule in this differential diagnosis. If there's none, so please don't, all right? You don't have to do CD10 for nothing. It's a waste of money and resources. Okay, so I'll go on with case 3. Mr. H, a 45-year-old Myanmar male, presented with anterior neck swelling for 18 months, associated with dysphagia and shortness of breath. So it sounds very aggressive lesion. So CT scan was performed, show a very huge thyroid, 13 centimeter, with retrosternal extension and a tracheal stenosis associated with multiple cervical lymphadenopathy. So of course, in this context, you will suspect thyroid malignancy, or maybe could that be a lymphoma. So a thyroid FNA was performed. Okay, looking at this, all right, so it's a very cellular smears, low magnification. You can see they are in very tight cohesive sheets. Some are very singly dispersed. So when you look at this, yeah, it's not lymphoma already. Okay, so all right, so you can see that there's cells, very loosely cohesive cells. They are forming weak microfollicular patterns, right? So you can see the cells are very pale, you know, powdery chromatin nuclei. Okay, but all right, so there's discohesion with mild anisonucleosis. You can see here, these are bigger and the rest are smaller. Okay, so you can see better appreciate here. There are mild to moderate now nuclear anisonucleosis, but very pale powdery chromatin patterns. Very strangely, I actually searched through the entire tray to look for nuclear inclusion. I only managed to find a few, only one or two. A nuclear groove also not a lot, you know. So this actually this case actually poses a dilemma to me, you know, whether to call it a PTC or something else. But you know, looking at this pale chromatin pattern, powdery chromatin pattern with inclusion here and there and groove occasionally, very occasionally. So yeah, this is to show just macrophages to see if, yeah, it's like a cystic variant, you know, of a PTC. So yes, all right. So in areas in MGG, it shows a very crowding, nuclear crowding and overlapping. So, but in this area, you can see that the cell's not very irregular. It's actually rounding, you know, it's quite round. And MGG, and in this field, you can actually appreciate that there is presence of pseudo-nuclear, intranuclear pseudo-inclusions. So yeah, despite the dilemma, we actually, yeah, this is so you looking at the clinical and radiological findings. So we are dealing with a thyroid CA. So which entity we are going to put in is a dilemma to me. So because of the typical nuclear features of PTC, so I give a diagnosis of suspicious of a PTC, not very confident, not a diagnostic of PTC, but suspicious of PTC, but still is a Bethesda 5 that I have given. So fair enough, total thyroidectomy and total neck dissection is performed. So I cannot put a diagnostic of Bethesda of a 4 because they will do a lobectomy instead, right? So yeah, that's my decision. Okay, so it's a very huge thyroid. Okay, weighing 200 plus a gram, and the serial section show a total involvement by the tumors with whitish cut surface with extensive areas of necrosis noted. So you can appreciate that this is this tumor actually thinly yeah, quite encapsulated, composed of solid nests of tumor cells. Okay, so they are arranged in a solid trabeculae and insular pattern. So at higher magnification, you can see that there is some anisonucleosis, right? They have round to oval nuclei with inconspicuous nucleoli and abundant clear to eosinophilic cytoplasms. And you can appreciate the frequently seen mitosis. Areas of necrosis is seen. So in areas, lymphovascular invasion is also noted. So expectedly, the lymph node also show positive for malignancy. So a diagnosis of polydifferentiated carcinoma in cellular type with lymph node metastasis was given. So a bit on the discussion, FNA diagnosis of polydifferentiated thyroid carcinoma. I think it's highlighted by Prof. Sharifa earlier as well. Just a recap. Okay, so polydifferentiated thyroid carcinoma used to be recognized as a distinct entity since 2004 in the WHO classification. Previously, it was actually classified as a variant of a papillary and follicular thyroid carcinoma. Okay, so it's actually a neoplasm with morphologically, biologically, and molecular features overlap with that of well-differentiated thyroid carcinoma and anaplastic carcinoma. It's actually they carries the molecular mutation of well-differentiated thyroid carcinoma, the RAS and BRAF, and also the third promoter and the TP53 mutation, that of anaplastic thyroid carcinoma. So it account for, it's not very common, account for less than 7% of the total thyroid malignancy. It occurs in slightly older age group with a slight female preponderance. So this is taken from WHO, the latest WHO 2017. We use Turing criteria to diagnose polydifferentiated thyroid carcinoma histologically. So you need to have solid growth pattern, trabecular and insular growth pattern. This is the first criteria that you must fulfill before you call this entity. And they should not have the nuclear features of a papillary carcinoma. If you see that, then straight away you have to call it a solid variant or PTC, because the prognosis actually differ. And if there's none, then you will have to look for these features. If there's positive for necrosis, positive for mitosis, and convoluted nuclei, then you have to call this polydifferentiated thyroid carcinoma. If there's none, you go back to follicular carcinoma. Okay, so cytological diagnosis of polydifferentiated thyroid carcinoma actually very problematic due to the significant overlapping features with follicular neoplasm, PTC, and MTC, medullary thyroid carcinoma. So in this report, a recent report by this, I think it's a systematic review, they actually found that as high as 26% of cases reported this as malignant, but classify them as well-differentiated thyroid carcinoma, as in my case. So they failed to identify polydifferentiated thyroid carcinoma, and sad to say that 1/3 of the case actually put them as follicular neoplasia, and this patient will require a second surgery, because when you put as a Bethesda 4, the patient usually will undergo a lobectomy first, and then when you put when the histology come back as polydifferentiated thyroid carcinoma, the patient may have a second surgery to complete the total thyroidectomy. Okay, so these are some useful cytological features to diagnose a polydifferentiated thyroid carcinoma. As what mentioned by Prof. Sharifah earlier, this entity usually very cellular. They have they lack that of microfollicular pattern. They have a solid sheets, insular patterns, insular growth pattern. They have a peculiar nuclear palisading. Okay, we call it a peripheral garlanding of the nuclei. Okay, so you can appreciate they're like a BCC of the skin. They have this peripheral palisading, and they have this 3D cell clusters, very crowded nuclei. You cannot actually see them. Yeah. Okay. So some of them, they have in other areas you may appreciate they are loose. They're loosely cohesive. They're very very malignant looking to you, but you don't know whether they put it a well differentiated or poorly differentiated carcinoma. All right. In at times you can see they have a trabecular growth pattern. Yeah, trabecular arrangement. So this is what I call a peripheral garlanding. It's like a nuclear palisading of at the periphery. You can see a transgressing blood vessels. Not only in this entity, it's actually very a hallmark in Hutter cell neoplasia. And you can see endothelial enveloping. Okay, in some cases. So occasionally you can appreciate there are intranuclear pseudo-inclusion. That's where they mimics the medullary thyroid carcinoma. They may mimic PTC. Yeah. So rarely, in this review, they out of 7 cases, they actually found 1 cases with nuclear inclusion. Nuclear groove, mimic that of a PTC, and they tend to have a nuclear anisonucleosis. And like what Dr. Yati's case, they also have this basement membrane-like material. So you may be confused with a salivary gland neoplasia as well, right? So this is a very difficult entity. So these are the diagnostic features that is summarized in this review that you have to okay, so these are the features. Okay, these are the cytological features that is most predictive of this fully differentiated thyroid carcinoma that as highlighted here. You have to appreciate that they must be very tightly cohesive, very cellular, insular, solid trabecular groove pattern. They may be singly dispersed, right? Very high NC ratio, and yeah, nuclear crowding and nuclear overlapping. So these are the 4 features. 1, 2, 3, 4. These are the 4 features that very predictive of poorly differentiated thyroid carcinoma, not very diagnostic. All right. You may ask, is there any helpful ancillary studies? So far, there's none, except that you want to rule out medullary thyroid carcinoma. So this is rare, a brought home message, a rare but very important entity. Try not to miss. Sometimes cytological were actually quite difficult, but we try not to miss this entity because the most we can do is to categorize them as a category 5, rather than a 4, because is the implication is different because the patient will undergo a second surgery. Okay, with that, I thank you very much.
Thank you, Wong, for sharing those interesting cases with us.